please.
Sabah al-Khair, Salam alaikum. It's my great pleasure and my great honor to be here today with you, especially as a medical oncologist in this very important meeting. Today, I am assigned to speak about the role of systemic therapy in downstaging hepatocellular carcinoma. And I really feel very lucky because today we have with us Dr. Chelis, who is an expert in this field, and I really hope in a very educative and informative discussion later. Here are my disclosures. So, briefly, this is my agenda. We will spend a few minutes discussing about the definitions. We will review some retrospective data. We will review the only available prospective data. You know, we, the medical oncologists, we are very familiar to speak about big, randomized, multicentric trials with hundreds or even thousands of patients in each arm. However, this is not the case because this is one of the most promising and new fields in liver, in HCC oncology. And we will see some things that need to be further discussed, and we will see the future perspectives. So, definitions, very important. In liver oncology, we have so many different terms for our treatment. So, we have adjuvant, neoadjuvant, bridging, downstaging, conversion, or perioperative treatment. So, generally, an adjuvant treatment is a treatment that is given after a definitive treatment like transplant or surgery. And a neoadjuvant treatment is a treatment that applies to patients that are fit for surgery or for transplant, and we need to offer a treatment that might kill the micrometastatic disease or make the life of the surgeon easier. When we call about bridging, again, the patient is fit for transplant, but the patient has to wait because of the list. And when we speak about conversion therapy, we are talking only about surgery. Conversion therapy applies to surgery. When we speak about downstaging, mainly applies for transplant, but also it can be applied to surgery. And perioperative treatment is the treatment that might start before surgery and continue after surgery. So today I will focus on downstaging, I will focus on transplantation, and I will speak about systemic treatment, because this is the field that has been researched more. So we all agree that transplantation is the gold standard for curative intent treatment for HCC. And since now 30 years that has been established as it, we have two driving forces that try to increase the number of patients that are eligible for transplant. In one hand, we have the expansion of the criteria, let's say the Milan criteria, trying to offer this approach to more patients, and the other driving force is to downstage the tumor. That means patients that do not meet the criteria to make them fit in the criteria. These forces might seem that be opposite to one each other, but at the end they both contribute to the same outcome, to offer transplantation to more and more patients. So, what is the extent of expansion and what is the extent of downstaging? I will not focus at all at the expansion because this audience here is much more familiar than me in this discussion. But for both how to expand our criteria and how our downstage, the answer is it depends. If we expand too much the inclusion criteria, we might have more failures. And if we expand the downstaging, again, we will result in more and more failures. And of course, this was the cornerstone trial, the XXL trial, which was a randomized trial for patients that were not meeting the Milan criteria, and they received at that time, because if I remember correct, this trial was around 10 years ago, between 2010 and 2015. At that time, there were no systemic treatment really effective. We had only sorafenib with response rate less than 10%. So in this trial, they randomized patients after the downstaging with locoregional treatment to receive transplant or no transplant. And as you see, the hazard ratio is 0.2. That means a huge benefit of this strategy. And the trial closed early because it would be unethical to continue. So this has established downstaging with locoregional treatment as a standard practice. Of course, we need to have criteria. One of the most relevant and most widely approved criteria is the UNOS downstaging criteria. I will not spend more time on that. I'm sure that all of you are familiar with them. I need to say that there are no data for downstaging criteria for systemic treatment. All we use, we extrapolate data from locoregional treatments. So, given for granted that tumor downstaging followed by transplantation is effective, can we expand downstaging? Should we offer all comers, or we should restrict it, either using a continuous approach like the metro ticket probability of more than 50%, or a dichotomous approach? Or in other words, who should be considered for downstaging strategy? Now, what we know is that the dropout risk during downstaging and post-liver transplantation increase with the higher tumor burden at baseline. We have two trials, one from the United States and one from Europe. Both of them showed the same thing, and it's here, if you see, those who downstaging from UCSF criteria and those that meet upfront the Milan criteria have more or less the same recurrence rate. Okay, morphometric parameters are important, but can we incorporate biology of the tumor? Do we have any factors, any parameters that can reflect the tumor biology? Well, we don't have a very, very nice tool, but alpha fetoprotein is the only tool that we have that reflects tumor biology, and we know that it is important to incorporate it in our selection criteria if we want to increase the survival rate. So we need to understand that downstaging is different than debulking. In many cancers, we use debulking, like ovarian cancer. In HCC, debulking means almost nothing. There will be no benefit if we remove just part of the tumor. The tumor should be removed completely, and we need to have a comprehensive definition of the tumor burden up front. So the modern definition of tumor burden should include radiological data for CT, MRI, biological data from AFP, maybe PET-CT, and we have some preliminary results from the molecular biology and omics that should be incorporated in a tool that would be useful to predict who is fit or not fit for downstaging. Now, I will focus mainly on downstaging with immunotherapy-based combination. We have two main classes of drugs of immunotherapy. We have the anti-CTL4A inhibitors that are active in the early phase of immune response, and we have the late phase, which is the anti-PD-1 and anti-PD-L1. If I try to use a paradigm, the anti-CTLA is trying to increase the gas, increase the speed of the immune system, and when we use anti-PD-1, we are trying to release the brake that the tumor has activated in order to escape our immune system. Now, we have several phase 3 trials from the advanced and metastatic setting of HCC with many combinations. Not all of these trials were positive. Usually, monotherapy were non-positive trials. We have several combination strategies that have proven beneficial. The most important are these 4 trials in Brave 150, which is the combination of atezolizumab and bevacizumab, Himalaya trial, Chelis 310, and Checkmate 9DW. What I would like to highlight that in all these 4 studies that are the most important and we use in our practice, the response rate is between 20 and 30%. And this is a striking difference with the medication we used to have before, that we barely will have one complete response every 100 cases. So this was the fact that prompted the transplant oncology team to use this combination as a downstaging strategy. So first, after 2019 that in Brave 150 was published, we have a series of case reports that have published in the literature. Well, I will focus on it later, but one of the most important concerns is that if you give immunotherapy for a patient that's going to have transplant, you have very, very high chances to have a rejection reaction, and this is what was very, worrisome, and all researchers were afraid of it. So in this first 10 cases, we have around 40% rejection rate, but only in one of them there was a need for retransplantation, and none of them was reported as recurrence. And after, you see here a very nice case that we have a huge disease, received atezo-bev, you see that all the enhancing component has been disappeared. You see the surgical specimen of the cirrhotic liver, the tumor necrosis inside, and the pathology that shows exactly this necrosis. And then we have case series that used a small number of patients from many centers. The rejection rate was around 27%. One was from Mayo Clinic that used doublets, and in this, there were no recurrences, of course, only 5 cases. And finally, this year, we have the first and only, to my humble knowledge, data of a prospective trial that tried to use downstaging with immunotherapy before liver transplantation, the only prospective study so far. So this goes for patients with intermediate and advanced HCC, beyond up to 7, judged non-eligible for locoregional or surgical treatments. Most of them have already received the locoregional treatment, absence of extrahepatic disease, and without hepatic veins and or cava invasion. So it was 49 cases. Almost half of them downstage received at least 3 months of atezo-bev and then downstage to have transplantation. 23 of them were either there was a failure or liver decompensation or no compliance or adverse events, so they were excluded. From these 26 patients that were eligible for a transplant, actually 16 of them were already transplanting, and 10 of them not, either for personal or medical reasons or because they are in the waiting list. So the primary endpoint was safety and efficacy. So what were the patient's characteristics? 13 male, 3 female, most of them with hepatitis C virus HCC, as it is expected from Europe. As I told you, 15 out of 16 have received a locoregional treatment. The median IFP was almost 300. The median size of tumor was 6.5 centimeters. 8 out of 16 have multifocal disease, and 8 out of 16 have portal vein tumor thrombosis, that we know that it is considered as a contraindication for transplant, but we'll see that this is not the case here. And the median duration of atezo-bev was less than 5 months, and the median washout period was around 2 months. So, safety, 25% rejection rate, only 2 retransplantations needed, one patient died due to mixed delayed malfunction and mild rejection, and the 90 days morbidity and mortality was 62% and 6% respectively. What about the response rate? Radiological, we have 12 complete remissions and 10 pathologic complete remission, meaning that in the explanted liver there were no alive tumor cells. And there was a 62% concordance between radiology and pathology. So regarding the follow-up, the median follow-up was 16 months. Only one patient recurred of this 16, and the overall survival at 2 years was 90%, and the recurrence-free survival was 94%. So as a conclusion, liver transplant with objective complete or near complete response to atezo-bev is safe and effective. There is a recent meta-analysis that published in January of this year in Hepatology that used a very strict criteria for studies that would be selected and appraised, that recruited 91 HCC patients that have received immune checkpoint inhibitors before transplant. And what we have seen there, that we have 9% death, 9% recurrence, and 26% graft rejection, which is very similar to the immunoXSL trial. And what was important, that as you increase the washout period, the risk for rejection reduces. Also, patients with, that were elder have less rejection rate. And what was really interesting, that the patients that have rejection have very similar survival with the patients that they didn't. So as a highlight, they said that it is an acceptable approach. Increased age and washout period correlates with reduced chance of rejection. I speak already about transplantation. Can we use these checkpoint inhibitors before surgery? Well, we don't have prospective data. This is one of a large series from China with 128 cases that show that yes, it is feasible. And of course, it was a retrospective study and no randomization, but the patients that had surgery versus the patients that they did not have much, much better survival and progression-free survival. So what things to consider? Can you use systemic treatment as downstaging for patients with portal vein tumor thrombosis? You see here a very nice case. You see the enhancement component that almost disappears after treatment. And in the pathology specimen here, you see the necrosis inside the vessel. This patient achieved the pathologic complete response, and at 2 years, the patient was alive without any recurrence. And from immunoXSL study, they have 8 cases with portal vein tumor thrombosis. 7 of them achieved complete remission, and 1 converted from VP4 to VP2. So it's not an absolute contraindication, and in cases should be discussed case by case in the MDT. Can we use this combination as bridging therapy? The short answer is yes. There are some, 1 minute. So there are several case series that have proven that this strategy is feasible, and there are several trials ongoing. We always have to be very careful in this balance between the pre-liver transplant immunotherapy and the post-liver transplant immunosuppression. So the washout is very crucial. If we limit it, we risk the risk for rejection. If we increase it, we risk the risk for tumor progression. From a meta-analysis, they have proposed 4 weeks. I will take it with a pinch of salt. I think this is the minimum period, especially if you have a young patient. I will say 6 to 8 weeks will be a more appropriate washout period. Future perspectives, we have several ongoing trials. This one is the one that has already presented by Dr. Seri. The next wave will be the combination of locoregional and systemic treatment. We have already some trials presented in the intermediate state, like Emerald and TELIP-02. These trials were positive in terms of progression-free survival, but however not positive so far for overall survival, and give us some concerns if this can be used as a strategy as downstaging. So in all system guidelines now, successful downstaging has a central part, and as you see here from EASL, they have included systemic treatment as an option for downstaging. The take-home message. Downstaging with immunocheckpoint inhibitors is feasible. Further perspective trials are required. I would like to say that we like to think in boxes, to have algorithms. We should not be, not in life, but not only in medicine, we should not be close-minded. We should be open-minded. Whenever you start a treatment, you should not say that this is palliative definitively or curative definitively. You have to be ready to be surprised, and sometimes positively surprised. If you have a patient that you have started systemic treatment, and at some point you see that the patient, due to the good response, meets the criteria, you should also go back to the MDT and discuss the possibility for a curative treatment. Very careful selection is crucial. Adequate washout period is necessary to reduce the risk for rejection. Multidisciplinary team, and again multidisciplinary team, and again multidisciplinary team is the cornerstone of the management of HCC. And the combination of locoregional treatment and immunocheckpoint inhibitor is very promising downstaging strategy. What I would like to say that the best way to predict the future is to create it. We have the privilege to practice in a marvelous country that has resources, has expertise, has patients, and we should try to collaborate, and these meetings are very important in this direction, and to be able to put Saudi Arabia in the world map of research in the HCC, and we are very open to this project. Thank you for your attention.